Today, I'm going to talk a little bit about complications and adverse outcomes in urology, talk about recognition, reporting of adverse events or complications, avoidance, and we'll finish off with a discussion on disclosure of adverse outcomes or patient harm. The impetus for these rounds came out of our internal residency review last year, where we're filling out how we're teaching all the CanMeds criteria. And scholar and professional and manager and collaborator, we can all fill in quite easily, but we struggled trying to fill in how we're teaching health advocacy and how we're teaching communication skills. So this year, when we were putting together the grand round schedule, we thought that we'd have 1 or 2 rounds that would directly address this and bring up a discussion in our faculty about these sorts of issues. An overview of what we'll talk about today is we'll start with just simple definitions of complications versus adverse events. Then I want to talk about why it's important to have a standardized reporting system for complications. We'll then use complications of surgical positioning as our model and talk about some of the things we see on an everyday basis and how to avoid them. And then we'll talk about disclosure of adverse events. That's, likely the hardest part of this whole thing. When things go wrong, how do we talk to our patients? And hopefully, we can have a discussion amongst some of the more experienced staff members about how this actually goes. So when we're trying to optimize healthcare expenditures, obviously reducing adverse events and optimizing patient care is a central theme to the delivery of healthcare. Defining quality of care, however, is a difficult task. The rate of surgical complication becomes one surrogate marker of quality of care delivery. In the surgical complication literature, a complication is defined as any deviation from the ideal postoperative course. Ideal being difficult to define. More current complication literature defines complications as an undesirable, unintended, and direct result of an operation affecting the patient, which would not have occurred had the operation gone well as reasonably hoped. Adverse events, comparatively, as defined by the WHO, is an injury related to medical management and not simply a complication of the disease itself. This includes diagnosis and treatment, failure of diagnosis and treatment, as well as failures of systems or equipment, which result in patient harm. Today we'll talk about complications, adverse events, and we'll use the study of surgical positioning as an example. The exact incidence of complications of surgical positioning is quite variable, obviously. It depends on the nature of the surgery itself, numerous patient factors, as well as where the care is delivered. Some estimates in the literature are quite alarming. For major inpatient surgeries, overall, the risk of death or any major complication is quite significant, up to 0.4 to 0.8% in some papers. Many complications are seen as preventable, and this becomes a continued focus of healthcare delivery as institutions try to improve the quality of care and minimize complications. But in order to study complications, as we attempt to compare across surgical interventions or across facilities, we need a validated and well-defined way in which to collect and analyze the data. It's imperative that if we want to draw any meaningful conclusions, we have to be comparing apples to apples and oranges to oranges. And it's obviously, it's become clear that the way in which the data on surgical complications is obtained and reported is equally as important as the overall complication rate itself. The problem is that we currently don't have a universally accepted method of reporting and analyzing complication data, and it makes it almost impossible to compare complications across different surgical approaches or across institutions. This problem is well illustrated in this study that was published in the Journal of Urology in 2007. This is out of the group at Memorial Sloan Kettering. They investigated this phenomenon of reporting when they exhaustively reviewed literature on complications following radical prostatectomy, cystectomy, RPL&D, and nephrectomy. They found striking variability in the way in which complications were reported. When they looked at it, over 80%, or almost 80%, did not define their criteria to be included as a major or minor complication. And of those that did define their criteria, there were 26 different definitions for a major complication. 2/3 of these did not even report complication severity. And over half did not report the duration over which complication data was collected. So it makes a comparison of these trials and the complications that are seen quite difficult. It underscores the requirement for a universally accepted method of measuring these complications and reporting them. So standardization of reporting promotes and ensures and it facilitates feedback to surgeons to ensure that they're providing quality care. It allows feedback to the structure to make sure that service is delivered in an appropriate way, and it also ensures that when service is compared, it's based upon appropriate means. It needs to take into account patients' baseline characteristics to allow us to calculate the observed complication rates that are reported versus those that might be expected. It would be unfair to take a look at the complication data out of cystectomies at Vancouver General Hospital versus the cystectomies that are maybe done at a community hospital in a healthier population overall. And it gets into the calculation of expected versus observed ratios. Many have likely heard of the American College of Surgeons National Surgical Quality Improvement Project, or the NSQIP. The NSQIP serves as an example of the importance of tracking and reporting surgical complication rates, and it provides a venue for facilities to join in this national program. It was in the late 1980s that the veterans hospitals in the United States came under a great deal of public scrutiny in the media, as there was the perception that their mortality rate and morbidity rate far exceeded that of the national average. It was so commonly talked about in the media that Congress got involved, and they actually passed a law stating that the VA hospitals had to report their surgical outcomes in comparison to national averages. The problem was in the late 1980s there were no national averages, and there was no way of standardizing this data analysis. So out of that grew the NSQIP. It allowed a risk-adjusted manner of comparing odds, expected versus observed complication rates. The NSQIP serves as a database of patient records, outcomes, complication rates, their interventions, as well as patient comorbidities and other conditions. It includes information on patient demographics, the surgical profile, the surgery itself completed, preoperative data, as well as intraoperative and postoperative complications over a defined period of time. This is all collected in a national database and allows institutions to compare against the national average. This implementation of standardized data collection, data analysis, and review was quite successful in the VA hospitals. In the late 1980s, it actually was shown to result in a 30% decrease in 30-day mortality and a 45% decrease in surgical morbidity. And it just serves as a good example of how this standardized way in collecting complication data serves as a means to improve patient care. It's probably likely due to partially the Hawthorne effect, which is simply that when people are observed and they know they're being watched, they perform better. But it also provides a mean of structured feedback to the institutions that allow changes in service delivery and improvement in care. Private hospital use and use by hospitals in Canada has also been resulted in quality improvement in most centers and reductions in patient harm. This is where we're heading in Canada. Currently, right now, the tracking of complication data is on the shoulders of the surgeon. There's rare institutional chart reviews that look at complication data, and if it's not produced in a serious adverse event incident report, usually if there's a big adverse event in the operating room initiated by the nursing, it's not tracked. So I was talking with Dr. Gourlay yesterday, and he said if I wanted to look back at my blood transfusion rate versus another surgeon, it would be an extraordinary task, because currently we don't have this central database looking at patient outcomes. Recently, hospitals in British Columbia have really gotten on board to join the NSQIP. VGH, St. Paul's, UBC Hospital are all members of this, and Dr. Patterson knows that Surrey Hospital, Burnaby, have implemented this, and there have been quite some growing pains. Obviously, it's a huge undertaking to get the infrastructure in place to mine the data, input the data, analyze the data, and then provide a structured feedback form. But this is where we're heading in the realm of surgical complication reporting.
Who's doing that? Is that each hospital setting up each infrastructure?
Each hospital, yeah, they have their own definitions of harm, what a complication is defined as, and its input. Yeah. It's medical records. So there's people whose full-time job it is to go through medical records, scan the complication, the pre-op comorbidities, and put them into this database. I think that's partially why VGH has gone to the dictated discharge summary, because that is one method in which they glean the information. But the exhaustive chart reviews are obviously labor intensive. They figure for every 2,000 patient data points put into the system, they need one employee to do it. So it's a labor intensive process.
Just a quick question, Brian. My understanding is that they only take a random sample of a few
currently.
every couple of weeks.
Yeah, currently.
Your understanding, or do they actually look at all the cases?
Well, right now it's random chart review of cases not under the NSQIP. It's under other standardized methods, just to ensure that the rates reported by each hospital in British Columbia are the same. But this NSQIP is meant to be an exhaustive input of as much data as possible out of the hospital.
It's still going to be random sample.
Yeah.
Because of the volume of work that each of the trained reviewers are something nursing. Ours for VA came from infection control. There's a person from CHC, would be somebody from Richmond. I don't know where they got which department they came from. Right now, they're just going through the process of creating up the definitions, so that there's no problem in terms of what's deemed emergency surgery versus elective surgery, and the data itself is collected and then sent in centrally, and the reports are then sent back, which are risk adjusted versus
Mm-hmm.
Brian, just one other question. Has anyone looked at issues with sampling error and then accuracy of these measurements? Because our understanding is they're only measuring at best 10% of the charts that are coming through. Whenever you have such a small sample size, it's going to be representative. So has someone done that kind of measurement?
Yeah, there's been a lot of discussion on that, because the data itself is only as good as what's in the chart as well and what's documented. So it depends on surgeon documentation of all these pre-op comorbidities that we actually write down that a patient got a urinary tract infection. But yeah, like you said, there is variability, but it's the best feedback mechanism we have.
How good is it, though? That's the question. How accurate is it?
I don't know.
Looked at the sample versus maybe auditing more than 50%.
I didn't come across any comparisons like that. But you would think that if across institutions, if the database is large enough, that the sampling should be, the variability should be decreased.
Only 10% or less.
Yeah. Okay. So we've been talking a lot about quality of care, and admittedly the assessment of quality is difficult. And most often the quality boils down to outcomes measures, and outcomes measures are seen by patients and surgeons as what we think of as important. And for surgical outcomes, we usually think of the chance of complication as quality of care. In 1992, Clavien was the first one in the surgical literature to publish a paper in the Journal of Surgery that suggested a standardized way of reporting complications, and it's based upon the therapeutic interventions required. The Clavien classification system originally stratified patients into 5 categories of complication. Over the years, it's been modified, and it's now referred to as the modified Clavien or the Clavien-Dindo classification of complications. And although there's no universally accepted or mandated method of reporting complications in the literature, this seems to be what the urologic literature has suggested is the way that complications should be presented. So the most recent version of the Clavien classification system consists of 7 subgroups, 5 grades. Grade 1 being any deviation from the normal postoperative course, not requiring surgical or pharmacologic intervention. It allows for antiemetics, antipyretics, analgesics, diuretics, and it also includes wound infections open at the bedside. Class 2 complications are complications that require pharmacologic treatment. This includes blood transfusion, TPN, enteral tube feeds, antibiotics, those sorts of complications. Grade 3 classifications are complications that require surgical, endoscopic, or radiologic intervention. They're classified into whether or not it's required under general anesthesia or not. Examples of 3A would be a nephrostomy tube, or 3B being internal stent placement post partial nephrectomy. Class 4 are any life-threatening complications, being single organ or multi-organ dysfunction. Class 4A, a good example, would be dialysis, and Class 5 being as death. And it's suggested that only by having these generalized classification system and presenting our data when we publish papers in the urologic literature in this way, that we can start to make meaningful comparisons. And
What time period does that apply to?
the standard definition is 30 days. Typically after, it's suggested in some of the reviews on presentation of complications in literature that you put a D and then a 30 or a 90 or a 120. Minimum 30 days is suggested. So I want to switch gears a little bit and use complications of surgical positioning as a model for complications and adverse events. You know, these are largely preventable occurrences, and it brings up the discussion of at the end of how we talk about these with our patients. So the inspiration for this talk is a recent case that I saw of a 45-year-old female. She was a healthy, living-related kidney donor. She had no past medical history, had no comorbidities, was thin, active in sports, and she underwent a left laparoscopic donor nephrectomy. She was positioned in the right lateral decubitus position in the standard manner on a beanbag. Operative time was typical operative time for a laparoscopic donor, just over 2 hours. She was positioned in the standard manner, well padded as we usually do, her elbows, wrists. She didn't have an axillary roll because we felt her positioning was fine. Her blood pressure cuff was on her dependent arm. The procedure itself went without complication, but in the recovery room, when she awoke, she had numbness and weakness in her right hand. She had no grip strength in her right hand, was unable to extend her wrist, fingers, or thumb. She had numbness and weakness in the radial nerve distribution over the medial dorsum of her hand. It was unclear at that time whether it was surgical positioning, pressure points, position of the blood pressure cuff that was the exact etiology. And unfortunately, this didn't heal quickly. She took approximately 8 months following the surgery for her to regain function and get back to work. She required extensive physiotherapy, splinting. She was off work. Fortunately, about 10 months after the surgery, she was just reassessed and is back to full activities and strength. So we can see that these are devastating injuries, largely preventable, and I think it is worthwhile us considering them this morning. So with this case in mind, let's look at our most commonly seen surgical positions, broken down by position and the risk of injury. So we'll look at supine prone, the lateral decubitus, the lithotomy position, and then we'll take a look at some of the considerations of robot positioning as we see that when people are held in these extremes of position. So when we're discussing complications, we're mainly, the mechanisms we're mainly talking about are pressure, shearing forces or friction, or mechanical hyperextension injuries. Compression on or traction on the nerves leads to ischemia of the vasa nervosum, which is the blood supply to the nerve, which in turn can lead to ischemic injuries. As you might recall, there's 3 types of nerve injuries that can occur: neuropraxia, axonotmesis, and neurotmesis. Neuropraxia refers to the mildest of injuries with expected full recovery. The nerve axon and myelin sheath remains intact, and it's thought that intraneural edema decreases nerve transmission of impulses. So this results in a temporary loss of function only, and recovery of function usually lasts hours to many months with expected full recovery. This is kind of sitting on your hand and it falling asleep. Axonotmesis is a more severe injury that refers to disruption of the axon itself. The myelin sheath, so the highway in which the nerve travels, is not disrupted, so it allows the conduit for nerve regeneration. So the nerve remains in continuity, but the nerve distal to the injury, not in continuity with the cell body, degenerates through a process called Wallerian degeneration, and it takes many months for a nerve recovery to occur. This is thought to occur about 1 to 3 millimeters per day, so depending on how far your injury is from the cell body, recovery can take months to years. And the final category is typically not seen in positioning injuries and more in transection injuries, which is neurotmesis, where there's complete disruption of the neuron axon and myelin sheath. So regeneration does not have a conduit in which to form, and it typically results in neuroma formation and painful neuromas. Multiple risk factors have been implicated in positioning injuries, including patient age, their comorbidities, vascular disease, obesity, diabetes and hypertension, as well as recent history of smoking. There's other surgical factors, obviously positioning, the length of time held in that position, and whether it's regional or general anesthesia utilized. Fortunately, urology does pretty well in this regard. This retrospective look at literature looked at some almost 400,000 cases and their reported nerve injuries, and urologic injury was less common, but still occurred in about 1 in 4,000 patients. So some of the specific considerations for supine position are one of our most common positions. It's obviously the dorsal recumbent position with the upper extremities out or tucked in at the side. The dependent areas include the scapula, posterior superior spine, the occipits, thoracic and sacral vertebrae, elbows and heels, and these are the body parts at risk. There's a few considerations I'd like to briefly point out. The main neuropathy associated with supine injury is the ulnar nerve neuropathy. It results from pressure on the ulnar groove just in behind the elbow. It can be caused by forearm hyperextension, elbow overflexion, or even a misplaced blood pressure cuff. That's why the recommendation that arms, when they're tucked, should be at the neutral side, not in extremes of flexion or extension, with care taken not to have pressure on the elbow. The ulnar nerve, as you recall, supplies the flexor muscles of the wrist and hand, and some of the muscles involved in thumb apposition and grip. An injury to these nerves results in sensory and motor deficits, and the sensory, as you recall, is the lateral part of the hand and the small finger. Another consideration in supine is brachial plexus injuries. Fortunately, they're rare, but they can be devastating as they supply all the sensory and motor innervation to the entire upper limb. So it's C5 to T1 injuries, including radian, medial, ulnar, musculo, cutaneous, all sensory and motor to the limb. And as you recall, these ones are often injured in childbirth, but can be injured in surgical positioning as well. It's usually hyperabduction of the shoulder beyond 90 degrees. I know we all want room to get in there, but shoulders should not be above 90 degrees. And the head should be maintained in a neutral position. External rotation of the shoulder and contralateral flexion of the head was one of those physical exams that we learned in medical school for impingement syndrome on the brachial plexus. So when we're positioning, we have to keep this in mind. Prolonged impingement can result in prolonged disability.
Has there been a recent brachial plexus injury in our department?
In our department? I don't know in our department, no. Yeah. You did? Yeah.
Yeah. We had a neuropathy brachial plexus
From prone positioning, yeah, we'll talk about that. Yeah, it's a real phenomenon. This paper in 2009 looked at just over 100 patients, and they had 3 brachial nerve injuries.
3
out of 100.
Radical prostatectomy.
Yeah, which is astounding. But it just goes to show that attention to positioning is important, because it could be this prevalent if we didn't take care as we do.
Right. We also had one. I think the most common is not necessarily positioning, but sometimes the arm falls off the arm board.
Yeah.
So you position properly. But I think that's the most common that actually happens.
Yeah.
In the case the arm slips on.
Yeah.
So
Yeah.
hangs.
Right.
Pardon me? Yeah.
Ryan, would you consider tucking safer than? That's also often a discussion. You can tuck or you can put it out. It doesn't really matter to the surgeon. But
Yeah.
I wonder if one's safer.
Yeah, I don't. They're so rare. I don't know that anyone could ever look at whether it becomes a risk factor, but it matters. Yeah.
They want to know.
Yeah.
Yeah.
Yeah. As long as they're not hyperextended beyond 90 degrees and well supported, the brachial plexus isn't at risk. Another consideration in the supine position is we often put these patients in the hyperextended spine position. And before looking at this, I hadn't really thought a lot of it. Yes, it looks uncomfortable, but when they wake up and they have a little bit of back pain, that's one thing. But there have been reports in the literature of fulminant liver failure, thought to be from partial IVC occlusion and increased venous pressure. And there's more than one of these described in the literature, as well as these devastating spinal ischemia and infarction from, again, IVC compression. So I think when we put these patients in extension and flexion or extension at the ASIS, we have to be cognizant that this is real risk. This is just a picture of one of the papers that shows the resulting spinal cord ischemia following positioning in the hyperlordotic or extended position. So a real complication of hyperextension. So it's suggested that hyperextension shouldn't exceed about 10 degrees, and that's the recommendation by the American College of Anesthesia. As Dr. Patterson was saying, the prone position is prone to complications. Sorry. And the unique anatomic regions that are at risk is mainly the brachial plexus. When you're positioned prone, it's very important that, again, you don't hyper extend the shoulders or you keep them tucked in the neutral position at the side. In the prone position, cervical injuries are also important, and not just to the musculature itself, but excessive rotation of the head has been shown in some case series to cause vertebral artery and carotid artery strokes. So positioning in the prone position can cause devastating complications. So head positioning in the neutral position is seen as quite important in this. I know that when we do PCNLs, not much consideration is given to the positioning of the head, other than where the ET tube is easy to come out.
We stick it to one side.
What's that?
If you notice, put it to one side, I can make it goes, but they
You
have-
look at your up shoulder. From an anesthetic point of view, positioning in the prone position obviously compromises respiratory function with decreased venous return. It decreases your pulmonary compliance and diaphragmatic exertion. And positioning of chest rolls is suggested. I personally have never seen a chest roll put in the proper way. I usually see it across the chest so that the belly hangs down. It's suggested that they actually go bilaterally between the shoulders and the ASIS to allow for diaphragmatic excursion and to lift the entire chest off the table. And again, in the prone position, padding pressure points, knees bent, pillow under the toes to help decrease injury. So next position we'll briefly talk about is the lateral decubitus position, or the position that was seen in our case. Obviously, the areas susceptible to injury are those on the head, the acromion, the axilla or brachial plexus, along the humerus where the radial nerve runs, behind the elbow, the anterior superior iliac spine, and the lateral trochanter and malleolus. So proper lateral decubitus positioning has to keep these pressure points in mind. You need your arms well supported, no greater than 90 degrees, upper arm well supported. The lower shoulder should be slightly anterior to decrease compressive forces that are directly on the shoulder and the acromion, and decrease pressure on the brachial plexus. And it also helps to minimize pressure along that humeral groove that runs on the lateral part of the shoulder where the radial nerve travels. Brachial plexus injuries in the lateral decubitus are the most common. And it's actually been shown that in selective patients in this retrospective review that the use of a properly placed axillary roll did decrease brachial nerve palsies. Unfortunately, a lot of axillary rolls are not placed in the proper way. They should be well out of the axilla. If the idea is to offload the pressure from the axilla, having the roll right up in there doesn't make much sense. So it should be placed against the chest wall. It should be small and soft, and simply provide a little bit of cushion for the structures superior to it. The lateral decubitus position is associated with the largest chance of pressure sores and skin breakdown. And I was actually astonished by this statistic that if you follow people for 30 days after their operation, almost 15% of them will have some evidence of skin breakdown, either from the positioning dependent side or from the tape and devices used to secure them.
Is it better to use like a towel versus a foam pad versus a gel roll?
There's differences between gel pads and foam. The use of that stippled foam that has been eggshell foam, has been shown not to decrease compressive forces and to not be associated with increased nerve injuries. But the use of the gels has been shown to decrease pressure injuries. Interestingly, some of us are against using the vac pack because no one would like to sleep on a hard sand surface like that, but it's never been associated with increase in positioning injuries. Another interesting consideration is the risk for rhabdomyolysis. I think a lot of this goes undetected. And in a retrospective review by Glassman out of Philadelphia, they looked at 600 laparoscopic kidney surgeries, kidney and adrenal surgeries, and they found the incidence of documented rhabdomyolysis to be almost a little over 0.5%. So 1 in 200 patients get symptomatic rhabdomyolysis simply from positioning considerations. This is probably underreported because it depends on it being recognized. And I had really not considered this significantly before. You can see ischemic changes to the tissue in animal models as early as 2 hours that are non-recoverable rhabdo and irreversible by 7 hours. We're all familiar with the lithotomy position. The classic is ASIS at the break. Dan will make fun of us because most of us don't do it right, but it should be proper hip flexion, almost 90 degrees, the lower limb parallel to the floor, with the legs abducted 30 to 45 degrees with limited external rotation of the hips. The nerve most at risk is the common peroneal nerve that runs just lateral on the knee there in the fibular groove. And it's at risk for pressure between the head of the stirrup or the candy cane and needs padding. It results in a motor neuropraxia with the foot drop. The one retrospective review out of the Mayo Clinic showed this was a real phenomenon, that about 1 in 3,600 patients get a lasting common peroneal nerve neuropraxia that lasts greater than 3 months. They found risk factors of thin body size, tobacco use, and surgery. Other reported nerve injuries are the obturator nerve from excessive abduction of the hips, the lateral femoral cutaneous from abduction or often associated with retractor injury, or the sciatic from prolonged frog-legging, also called the, what do they call it, the college drunk neuropathy, where they fall asleep drunk with their legs spread apart.
I also mentioned about a patient who had repaired melanoma, so patient who was ambulatory, was in a prolonged position for a reconstructive case, and post-op was not ambulatory afterwards. And the thought was the scar from her surgical repair on the back, there was a certain degree of tethering. Because she was in prolonged lithotomy, that
The femoral.
yeah, so far as I was aware, did not recover.
Yeah.
So I think it's especially important to remember for your patients.
Yeah, yeah.
Your positioning.
Patients with previous surgery. So we'll talk a little bit about robotic positioning, or the upside-down patient. As you know, a lot of these patients are in greater than 40 degrees in Trendelenburg. It's necessary for proper visualization. Fortunately, surprisingly, complications are rare in this position, and there's very few documented complications. Obviously, there's physiologic considerations. If you're standing on your head, you get pooling in the blood in the thorax and head, causing intracranial hypertension. This has been studied because people were quite concerned about this, and it's been shown that there is a slight reduction in cerebral tissue oxygenation, but autoregulation maintains this within a safe limit, and it's only really a problem in those with pre-existing carotid artery disease. There have been only 1 or 2 reports in the literature of catastrophic CVAs in this position. The one that we often see is laryngeal or facial edema due to the decreased venous return. You see their cornea get edematous, and laryngeal edema causes the need for prolonged ventilation. Fortunately, this is rare, and I know Dr. Goldenberg takes care to get the anesthetist to avoid excessive fluid administration, because this helps in being able to see what you're doing when you're trying to do your anastomosis, but it also decreases the facial edema and laryngeal edema. And Manny Menon describes limiting fluid throughout the operation to less than 2 liters with fluid boluses at completion, and they have only had 1 in 1,500 of their patients needing prolonged ventilation afterwards for their laryngeal edema. Obviously, Manny Menon is doing his operations in just over 2 hours with estimated blood loss of about 100 cc. So it might not be typical of what everybody experiences, but the data's there. One complication that gets a lot of press is the postoperative vision loss, or the posterior ischemic optic neuropathy. And there's actually only 2 cases that have been reported in the literature, but it makes it into every single discussion on robotic positioning and why we shouldn't do robotics. It's thought to be associated with prolonged positioning and increased blood loss, but a recent study has measured the intraocular pressure in 30 consecutive patients and showed that it only changed by about 13 millimeters of mercury. In a typical patient without pre-existing glaucoma, this is inconsequential. The postoperative vision loss has been well described in other surgical procedures, including open radical prostatectomy. And so it's probably mainly associated with shock and increased blood loss and decreased perfusion rather than the position itself. But it always comes up. I know it's come up in the operating room when we've been there before. So this is just a summary slide of the considerations and the positions that are at risk. This is available in the AUA update series, which is quite a good resource. I'll let you take a quick look at it. We've talked about a lot of them. Upper extremities being brachial plexus, radial nerve, ulnar nerve, and median being the main considerations. Early recognition of these injuries is really important because in a lot of ways they're avoidable and patients don't expect them. So we should early involvement of neurology consultation is suggested by all boards and risk management members. Typically an EMG is done, and it can be helpful to both locate the injury and rule out pre-existing injuries. There shouldn't be muscle transmission changes that early on. So EMG, electromyogram studies that are abnormal at the beginning suggest a pre-existing injury, whereas nerve conduction studies will be abnormal. And you can actually locate the nerve, the site of injury, so to ensure that it is indeed a peripheral nerve injury and not a central stroke or missed CVA. Therapy for these injuries mainly consists of physio, splinting to avoid further contractures or disability, and symptomatic treatment for pain. And as we talked about earlier, the prognosis of these injuries is variable. There's really been no series in the literature that I could find that would give a number on these, 60% are expected to return, simply because the injuries are so variable. Again, neuropraxias usually recover in most cases, and axonal and myelin injuries are more variable. So with that in mind, we thought that we'd just take a few minutes here to try to get a discussion about what we do after we have these injuries. We're put in a delicate position here where patients have trusted us while they're asleep, and they wake up with these adverse events. Talk a little bit about disclosure, and obviously we know disclosure is important, but why? From an ethical point of view, failure to disclose essentially undermines the public trust in us. They're trusting us that while they're asleep, we're going to take good care of you. And if we don't fully disclose, that is harmed. Patients can be harmed further if they don't know what happened, and failure to disclose undermines any chance of us improving the system so it doesn't happen again. And in this day and age where patient autonomy is necessary, it used to be that we didn't want to burden patients with their complications, whereas now I think it's not really accepted to keep them out of the loop. From a legal point of view, some physicians, I think, are concerned that adverse events, if we report them or disclose them, that it'll incite litigation. But this has been shown not to be the case. The Canadian Institute of Patient Safety has a large legal paper that looked at the impact of disclosure on adverse event litigation, and they actually showed that it either doesn't change or has a positive impact on the chance of litigation. So by telling the patients, being honest, there's less chance of them suing. And in this paper they say that where harm suffered by the patient is mild to moderate, it decreases the frequency of litigation. On the contrary, cases that do go to court throw the book at those who haven't fully disclosed or were deliberately withholding information, and there's lots of cases in Canadian law where information was withheld and punitive damages were awarded larger than if they had not. Some physicians worry that if we disclose or apologize, that this is admission of guilt or omission, and actually in British Columbia there's an act called the Apology Act, believe it or not, that says that an apology is not an admission of fault or liability and actually can't be used against you in liability proceedings. From a policy standpoint, obviously every institution has a policy on disclosure of adverse events to patients. If you look on the VGH intraweb or St. Paul's, there's many manuals on what needs to be disclosed, how to disclose, who's involved, and there's structures in place at each hospital of risk management, as well as your CMPA, who can help you with issues on disclosure and talking about surgical errors. And over this is the last slide here, and over it mainly boils down to these recommendations. You know, when disclosing adverse events to patients, you need to seek assistance from those who can help you, your CMPA or your risk management people at your hospital. Promptly disclose the facts that you know without judgment or without assignment of blame. Outline the possible consequences of the adverse event or injury, and put in place a plan to rectify the harm and to prevent this from occurring to another patient. Again, avoid attributions of blame, and apologies and saying you're sorry are appropriate. All guidelines suggest that we get early and often involvement of consulting services and second opinions. It helps patients know that they're being cared for and you're taking it seriously. And ensuring appropriate follow-up, future discussions with family and patients is important. And again, all of them say documentation is important. You know, a difficult subject, but it's kind of interesting to think about, and how we maintain our relationship with our patients when bad things happen.